Good evening, everyone. My name is Akli Zetchi, and I'm an assistant professor of neurosurgery at Yale University. And most of my practice is at Greenwich Hospital. I'm very proud to be the first endowed chair, holder of the chair of neurovascular surgery, thanks to the immense generosity of the Jean and David Wallace Foundation. So I have no conflict of interest that are relevant to this talk. Really today, the objectives of this talk are to recognize the signs and symptoms of stroke and to understand that there are different types of strokes and to recognize that urgent therapies for stroke are time sensitive and that early detection of stroke can help enable access to urgent therapies. We will also review that most of the stroke treatments are available at Greenwich Hospital and what is exactly available. A few things that won't be covered today include seizures and traumatic head injury. My focus of interest has always been stroke and brain bleeds, and this is what we'll mostly cover today. Excuse me. Again, I apologize, my camera is not working. I'm not sure how questions work, but feel free to, I'm sure there will be period of questions at the end. Um, so stroke is the number one cause of disability among adults in the United States. Each year, close to 800,000 Americans will suffer from a stroke, and each year, about 150,000 will die from the sweets of a stroke. Close to American has a stroke every 40 seconds, and it's the number 5 cause of death amongst adults in the US. And unfortunately, only 10% of all strokes that hit the door in our emergency departments end up being eligible for acute treatments. Most of the strokes are ischemic, and that means that a blood clot or tiny piece of debris in a blood vessel will get dislodged from somewhere between the heart and the vessel supplying the brain and will cause a blockage in the blood vessel, and the area of the brain that is supplied by this blood vessel will or may end up suffering permanent injury, which can lead to disability and or death. In about 13 to 15% of the cases, stroke can be caused by a brain bleed. And most of these bleeds are spontaneous, so that's very different from a brain bleed caused from a traumatic injury. We're talking about a vessel that spontaneously ruptures and bleeds, and usually there is an underlying cause, which can be a brain aneurysm or a brain vascular malformation that we call a brain AVM, or more commonly, it is due to uncontrolled high blood pressure. So in stroke, we say that time is brain. And just to give you an idea, this is a graph representing the amount of time that is elapsed from the symptom onset. And this on the other axis, the probability of having a good outcome. And expectedly, in multiple trials, what has been shown is that whether you reopen the vessel or not, if you wait long enough, unfortunately, the chances of having a good outcome decrease quickly over time. And we say that in average, a typical stroke patient can lose up to 2 million neurons per minute in the territory that is at risk. So this is a bit of a simple picture to explain that there are different areas in the brain that are at risk at any moment during a stroke. So let's say this area is the area supplied by a blood vessel that is suddenly blocked by a blood clot. In red, you'll have an area that is the most fragile that will immediately or near immediately suffer permanent and irreversible injury. In blue and green, you have areas that may respond a bit differently, and because the brain has compensatory mechanisms, these areas can survive a bit longer. And if you're able to reopen the blood vessel and reestablish blood flow, these areas may be salvageable, but it's very time dependent. And that's why time is of essence in stroke treatment. So again, early diagnosis allows for access to emergent therapies that have been shown to increase the chances of a good neurological outcome. So what are the symptoms of stroke? There is an acronym that we call BFAST. B stands for balance, so sudden onset of balance. A lot of people have chronic issues with balance, so sometimes it's hard differentiate, but if someone is at baseline and suddenly is having sudden dizziness, vertigo, loss of balance, this would be a good reason to call 911 and come to the ER. If you're having sudden trouble with vision, whether it's a one side or both eyes, meaning that if you suddenly lose vision with one eye, or if you suddenly start seeing double, this may be an indicator of a stroke or imminent stroke. If we notice, or your close relative notices a change in your face, a droopy face, or an uneven smile, that's a sudden change, that may also be a sign of stroke. Weakness or numbness in one arm, a sudden speech difficulty that can be impaired speech, slurred speech, trouble finding your words, all of this could represent a stroke. And T stands for time. Call 911. The hospitals are a safe place despite the current COVID pandemic. And you should not delay care. You should not wait for the next day to call your PCP office. Really, you should get to the hospital or call 911. And the reason is these disabling symptoms can become permanent if nothing else is done and your brain doesn't recover well. And there are currently two main urgent therapies for stroke. The classic one is clot busting medication that we call TPA or alteplase or tenecteplase. The main limitation of TPA is that it has to be given within, in general, 3 to 4.5 hours from symptom onset, which limits a lot of people coming into the ER after this 4.5 hour mark. More recently, since 2015, a treatment has revolutionized stroke care. We call it mechanical thrombectomy. Mechanical thrombectomy is a scalpless, minimally invasive procedure that can be offered up to 24 hours after symptom onset after the start of a stroke. And down here, you can see 6 studies throughout the world that have studied in the most rigorous way patients randomized to groups ending up receiving TPA or best medical treatment, and patients receiving best medical treatment and mechanical thrombectomy, which are the bars in blue. And you can see that all trials have shown that patients receiving eligible for mechanical thrombectomy had a higher chance of having a good outcome that we call MRS 0 to 2. So what is a mechanical thrombectomy? Well, just like the cardiologists do to put stents in the heart, we can access the blood vessels from the groin usually, and we can use a long tube, plastic tube, very soft and flexible plastic tube that we call a catheter, that the neurointerventionalist will guide using X-ray imaging all the way into the vessels in the brain. So you can see in this picture, for example, there's a blood clot blocking a major artery called the middle cerebral artery that supplies a large part of the right brain in this picture. And by navigating a catheter, a subtle catheter, you can see a real picture here of the catheter. And you can deploy additional devices such as a stent retriever. This picture here gives you an idea of the size of these devices, right? This is someone's hand, fingers of someone. You can see the actual size of these stents, which is usually between 2 and 4 millimeters, 6 millimeters, sorry. So in real life, this is what it looks like. The patient is brought into a special procedure room called neuroangiography room, and we inject dye or contrast in the blood vessels. And this allows us to immediately identify the area where the blood clot is. For example, in this patient, this is a left-sided blood vessel. And you can see here that usually the vessel is dark, filled with contrast or dye. And you can see in this area here that the contrast doesn't fill it. There's a round structure that is the actual blood clot. And so what we did in this case is bring in a catheter, which is a plastic tube that you can see on the X-ray here. And through the plastic tube, we aspirated the clot out. And you can see on the follow-up imaging after the procedure that this round structure, the blood clot, is not there anymore. So at Greenwich Hospital, when someone comes in and is identified to be a good candidate for mechanical thrombectomy, a big team is alerted, and the success of this treatment is really dependent on the timely activation of workflow that starts before the hospital by the emergency medical services identifying the stroke on field, or at least suspecting it, and calling what we call a stroke alert. The stroke alert will be communicated to the ER services, and immediately the patient will be brought into the CT scan for urgent imaging, because in stroke, imaging is key. It's not like in the heart where an EKG can quickly give you a hint that there is, or a diagnosis of a heart attack. Well, a stroke or a brain attack needs to be diagnosed with medical imaging. So urgent stroke treatments are available at Greenwich Hospital at any time of day or night. We are a certified stroke center by the American Heart Association. And that means that every year, very strict criteria regarding stroke care and stroke outcomes are being met or exceeded. And we have 24/7 access to sophisticated neurodiagnostic imaging. And me and other neurologists and neurosurgeons from the Yale Medicine practice or live in the community are on call 24/7. So how are these treatments possible? Well, Greenwich Hospital has acquired and invested a lot of resources, including what we call the BIPLANE angiography. And honestly, this is now the way to treat most of the disorders of the blood vessels of the brain. And what's a biplane angiography? Well, it's all a matter of point of view, right? So Prince William here, you may be thinking that he's not doing something nice. Well, if you look at it from another angle, it's not that bad. So same goes for complex, blood vessel structures, where if you look at this structure, what could be a brain aneurysm with a point of weakness here, and if you only have a single plane machine, so only one of these X-ray tube, then you look at this aneurysm from this angle, you may be thinking that this is actually what the aneurysm is. Whereas if you look at it from the other angle, you'll be able to recognize then the point of weakness and fragility in the aneurysm and modify your treatment plan accordingly. When I'm talking about advanced neuroimaging at Greenwich Hospital 24/7, we have a perfusion imaging that we call, and thanks to AI software analysis, within 10 minutes of imaging, acquiring the images, a software will provide these colored maps who are really for dummies and will help us quickly identify which patient is eligible for thrombectomy and make a decision on the fly. So for example, in green usually will be the territory of the brain that is at risk. So the software, for example, in this case, tells us that 150 milliliters of brain is at risk of having a permanent injury, but remains salvageable. And on the other hand here, the purple illustrates the area of the brain that is unfortunately already damaged or permanently injured, or we call the core infarct. And so you can see the large mismatch here, a ratio of 5.2. So certainly this patient is someone we rushed immediately into the cath lab, the catheter lab, the angiography suite, to try to reestablish blood flow, since there's so much tissue of the brain that is still salvageable at that point in time. So what is a neurovascular surgeon? Well, there's been a strong evolution of models of care in neurosurgery, and we all have become specialized, right? So if you have a back problem, you're going to go see a spine surgeon. Well, in the same thought, if you're having a blood vessels of the brain disorder, you may want to go see a neurovascular surgeon. Nowadays, most training programs in the United States and Canada, residents are not proficient when they come out fresh out of the program, and we have to end up doing additional subspecialty training. So in my case, for example, I spent 2 years training in those specific minimally invasive techniques, and I spent an additional year training in classic open cerebrovascular neurosurgery. A neurovascular surgeon will do surgery or place stents for carotid disease and blockage. We do open surgery for aneurysms and vascular malformations of the brain and spinal cord. And we treat via image-guided aneurysms and AVMs, nose and brain bleeds, and spinal fractures. So this is our team currently covering Greenwich Hospital and the whole Yale system. Dr. Matuk, Dr. Ebert, and Dr. Barras are my colleagues. Please feel free to write down the number below if you have any questions or would like to make an appointment to discuss a brain disorder. Now, we talked about the most common form of stroke called ischemic stroke, where again, a blood clot will get dislodged somewhere between the heart and the brain and cause a blockage, and this can lead to injury called a stroke. What about brain bleeds? Well, brain bleed is a type of stroke. Let's be honest and clear. A brain bleed can lead to as debilitating consequences and can also lead to death. A brain bleed, again, can only be diagnosed with medical imaging. And once a brain bleed is confirmed on a radiological scan, there are again urgent treatments that are time dependent and that can be immediately started to prevent worsening of the bleeding and expansion of the blood clot and to prevent secondary injury. For example, once a blood clot is identified, a bleeding is identified on imaging, the emergency physician will start blood pressure medication to prevent additional bleeding. We can start administering a seizure medication to prevent seizures, and so forth. A neurovascular surgeon will be consulted and can help identify and treat the source of the bleeding. So we've entered the era of scalpless neurosurgery in most of neurosurgery specialties, whether it's spine, oncology, or as in my case, neurovascular. And constant evolution in our field have enabled safe, quick, and effective treatment of aneurysms and other malformations of the blood vessels through a needle puncture in the wrist or the groin. So this is an example of the type of devices that we use nowadays to treat brain aneurysms. Again, the scale for these devices is in the range of 2 to 4 millimeters in general. And this is an example of a flexible stent that we call a flow diverter that we can implant inside a tiny blood vessel in the brain. And imagine that the vessel has an outpouching called an aneurysm. The stent will exclude the aneurysm out of the circulation and preserve the flow. So that's why it's called a flow diverter. Will divert the flow away from the lesion and preserve the flow going into the normal brain tissue. There have been other devices that we use and they're available. We put sometimes these intrasaccular devices that we call. So again, this is a normal blood vessel and you can see the outpouching here. This is a brain aneurysm. Again, you see it here. And what we can do is, again, through the blood vessel, through a puncture in the groin, we access the aneurysm and we deploy this filter who will over time prevent the blood flow from entering the pouch and prevent the risk of bleeding from these brain aneurysms. Again, all these treatments would not be possible without state-of-the-art technology and infrastructure such as a BIPLANE angiography. And this is an example of a type of brain bleed that we call the subarachnoid hemorrhage that we treated at Greenwich Hospital recently. A patient who had presented with the worst headache of their life and suddenly became very sleepy. And you can see in white here, the white around is the skull and the white here is the bleeding. And so we took the patient immediately to the interventional suite where, again, we injected dye in the blood vessels. And you can see here that there is an outpouching again. So this is a brain aneurysm. And after treatment, what you can see is when we inject the dye flows into the blood vessels, but does not enter and does not fill anymore the pouch. So the aneurysm is secured and the patient has no risk of additional bleeding following treatment. We can do 3D reconstructions. You can see here the coils, which is the type of very thin hair-like platinum devices and implants that we use to pack the pouch. You can see a balloon and wires here. So those are really nice 3D reconstructions that we can obtain, again, from the same angiography suite to understand better the lesions and really understand them in 3D. Same goes for brain arteriovenous malformation or vascular malformations. Another example of a patient we treated at Greenwich Hospital who had a brain bleed and that we took urgently in the middle of the night just for surgery. And subsequent imaging on angiography, we identified a vascular malformation that you can see here. We can see it here on 3D imaging, right? This is a normal blood vessel, and you can see here this tuft and sort of pack of abnormal vessels. And what we did in this specific case is we accessed the vessel. You can see here the shade of the catheter, the small plastic tube, through which we injected a type of glue, medical glue, to fill in this abnormal malformation and prevent it from bleeding again. So you'll tell me, well, how can I know or what are the signs and symptoms of a brain bleed? Well, some of them are similar to a stroke symptoms, right? So a balance, eyes, face, arms, speech. In addition, a brain bleed can be painful. It can have sudden onset of headaches, nausea, or vomiting out of the blue. And again, some patient will lose consciousness or start becoming drowsy or very sleepy. And some patients, the only thing that will alert us is that they start having a twitching, and the arm, leg, or face will start suddenly twitching, which is a type of seizures, right? And any of these symptoms, again, should alert anyone to call 911 immediately, because again, the sooner you get to the hospital, the faster we can treat you. So thank you for listening to me. I hope this was not too heavy, and I hope this was informative. Here are a few numbers. If you have any questions, if a member of your family had, stroke care, Greenwich, you have a question about follow-up or treatment, we now have a stroke nurse navigator, Sabrina. You can reach her Monday to Friday during regular work hours at this number. This is the number to reach the neurovascular surgery for Greenwich and Stamford. And here's my personal email in case you have any questions. Okay. I don't know if anyone has any question. I see a Q&A here. How many thrombectomies? The hospital. So Greenwich, we started the program, kicked off in January 2020. So we're just past year 2. So far, we've done close to 30 thrombectomies at Greenwich Hospital since the start of the program. As this Greenwich Hospital is part of Yale New Haven Health, and the system-wide, we perform close to 200 mechanical thrombectomies per year. The majority of them are done at Yale, obviously, but we now start doing them as well as Bridgeport Hospital. And so again, Greenwich, we do about, it's a very young program, but our numbers are increasing. Anyone else has a question? Again, if you have any additional questions, just feel free to email me or give us a call, and we'll be happy to get back to you. Again, thank you everyone for listening. Take care.